Hi, Caroline.
Hello.
Welcome to LoveRose Talks. I'd like to introduce you today as Caroline Michie, who is an oncologist at the Western General. And Caroline is joining us because she's going to tell us all a little bit about the journey that happens through cancer, depending on what stage you're at or where and what point you've been diagnosed.
Okay, well, I'm a medical oncologist, and there are different types. There's also radiation oncologists. And essentially, we just don't treat breast cancer all the same anymore. It very much comes down to different types. And there are probably lots more different types that we don't necessarily know about. But then in practice, there are 4 or 5, depending on the system you're using to look at. And that really shapes what we might recommend for a patient. So the traditional way of treating breast cancer was someone to have an operation, and then they would have chemotherapy afterwards, for example, if they needed it. And the real principle in chemotherapy is that we're looking to try to mop up any cells that might be left behind. And often there are not any left behind, but it's about trying to give someone the very best chance of cure. We don't like to tell the surgeons this, but they actually do the most important bits, and they cure by far the most people, and then we just add the little bits on the side. But we don't want them to have a big head, so we don't tell them that. But they're probably the most important, to be honest. And what we do as oncologists is either before the operation now, if you have a type of cancer that tends to respond really well to chemotherapy, we actually sometimes give that before an operation. And there's many different advantages to that, in that sometimes it allows us to avoid a mastectomy and just take away a little bit of tissue. But the real value for us in having your chemotherapy first is that we know whether it's working or not. And that might sound a little bit odd, but if you have your chemotherapy afterwards, there's not really a way of knowing if it's worked. And the reason it's really valuable to know if it's worked in some of these patients is because if we don't know how it's responded, then we can't individualize the treatment. We just have to give the same treatment to everybody. And for some cancers, we've actually got good evidence that if you haven't had as good a response as you might have liked, we've actually got some other things we can give you after your operation to give you the very best long-term cure. So just having that knowledge of has it responded or not is really helpful. And it's also quite nice for patients if it's responding well, because you're going through some side effects, and to know it's working is really reassuring. So if it's working well, we know patients get often have a really good outlook, and that's nice to know. And if it doesn't work so well, well, at least we know, and then we can do something extra and boost the chances. So that's really helpful. And then we also give chemotherapy still after an operation for some patients. We tend to use that more in patients who perhaps don't have the type of cancer that melts away with chemotherapy. So it very much comes down to the subtype of cancer. Also, lots of my colleagues give radiotherapy, and radiotherapy is really just X-ray treatment, trying to supercharge that area. So that's about trying to prevent the cancer growing again in the same area. So it only really has that main effect on the area you're sending those X-rays, but actually it has a survival benefit too. So radiotherapy is about trying to prevent what we call local recurrence, so the cancer growing again in the chest wall or the breast or the lymph nodes, depending where you're sending those X-rays. And then we often give hormone blocking therapy, things like tamoxifen. We do that for 5 or even 10 years now, or other drugs called letrozole, which work in a slightly different way. And they're really about depriving the body of estrogen. And we know again that by doing that, for people who have a cancer that that's suitable for, that can reduce their future recurrence rates. We also do some antibody treatment for people who have what's called a HER2 positive breast cancer, and they often have that for maybe even up to a year after their operation. And there are even new drugs coming through the market for even longer than that too. So things are moving all the time, and the pathways are changing, because just 2 years is a lot of time in breast cancer. So much exciting stuff coming through, and that's really positive. And we can see huge gains over the last 5 and 10 years. It's great. And then we also do clinical trials. So we're also trying to improve the outcomes all the time. So we have trials in the pre-op setting, we have trials in the post-op, trying to add another drug in, for example, to try to see if that can further reduce the recurrence rates. And then I also have a lot of patients we treat whose cancers are secondary breast cancer, and we're also doing trials in those patients too, and also giving them lots of different treatments. We again have so many different options nowadays, and I think the goalposts have changed so much over the last 10 to 20 years, such that I actually often do lectures for medical students, trying to say, these patients are doing so much better than maybe you learned at medical school, so always speak to the oncologist. So we have quite a few different things that we do. And then, of course, we look after patients who have had some complications from their treatment. And actually, you'd be surprised, most patients don't have many, but for those that do, they come into the ward and we help to try to hopefully make them better. So that's that in a nutshell.
That's brilliant, Caroline.
So for women who are kind of watching this, who are maybe at the start of their journey and they've gone to an appointment and they feel a little bit overwhelmed about what's about to happen to their body, obviously there's like lots of different, people react to things in different ways, but generally, what are women about to expect from these treatments, especially chemotherapy? And
okay, well, it does vary very much depending on the subtype of treatment, subtype of cancer that they have. For some people, actually, we're reducing the amount of chemotherapy they maybe had in the past for that type, because we realise that they don't maybe need as much treatment, and for other patients, we're giving slightly longer treatment. But for example, in Edinburgh, we changed our standard treatment recently, which is quite a lot better tolerated, and also actually some data suggests it's got even better results. So we're always trying all the time to reduce the toxicity. So I would honestly say that most patients say to me it's not as bad as they're expecting. The majority would say that. Not everybody, but I try to be quite reassuring, and we have such a big team trying to help with that. So for each treatment, we call each treatment a cycle. You might have 4 cycles or 6 cycles or 8 cycles. That's a kind of common number that you might have, and those might be every 2 weeks or every 3 weeks, depending on the treatment that you're being given. And usually a nurse, certainly in Edinburgh, would call you the day before your treatment and would run through all your side effects. So anything that's worrying you, you've got a great opportunity to talk about that. We also have specialist breast care nurses that are there to help support you, and Maggie's Centre is also a fabulous resource. So I would say, if you're feeling overwhelmed, write down all your worries, because when you go to these appointments, you never remember everything. No. We give a lot of time. We're not in a rush. We know these first appointments are really important in talking about what the results are, what do these mean, and why are we doing all these treatments. And I think it's really important to understand why we're doing them, because you'd be surprised how people have misconceptions, just the general public, about some things. If hair loss, for example, is often a huge thing for patients, but there are things we can do about that. So speak to your oncologist. Nothing is a stupid question, but do write things down, because I think it can be quite overwhelming, and definitely take somebody with you. There's so much information. Even in the COVID setting, for new patients, we're certainly allowing somebody to come with you. And I think it's really important to do that. And if you have any questions afterwards, say Maggie's or the breast care nurses are there to help. And ultimately, if they don't know the answer, they come and speak to us, and we're happy to take forward any queries. But I think the biggest thing for most patients is hair loss, for sure. And then from your point of view, the other thing is, if you are having more surgery than you might hope for, so if you might have to have a mastectomy, that's a really hard thing, particularly for a young person. So those are the 2 biggest things, I think, for patients in terms of their worries.
Yeah, so after treatment, you have to actually start your recovery, like psychologically and emotionally, and so it's okay to talk about hair loss, and it's okay to ask these questions that might seem vain, but actually it's a huge part of your recovery and getting back to life, isn't it?
Oh, absolutely. And nothing is ever vain. There's nothing we haven't heard before either. But I think, it's a really hard journey, and you're often on a treadmill. I think patients, you go straight, either you have your chemo first or your surgery first, and then you're straight into the next one, the next appointment, next results. Then you're straight into radiotherapy. And it's just, sometimes I find actually that period and that year after treatment finishes is a really hard time for people, because they actually get off the treadmill and then they just try and process what they've been through. And what they might have been through is loss of their hair. Some people definitely keep some eyebrows and eyelashes, but that's tricky. That obviously it gets better again, but that's been difficult for patients. Their nails aren't looking so good with some of our chemotherapies. They may have had quite significant surgery. And we know that as the years go by, body image is even more important. And I think you're right. I think when people are first diagnosed, they just think, get the cancer out. And that's absolutely normal. But equally, it's really important, because you're still you, and we still want you to feel like you again. And I think it's a journey of afterwards of just trying to get back to your old self. And I think that can be really hard. And there's really good courses at Maggie's Centre that help people, called the Moving Forward course, or the
Feel Good.
Yes, Look Good, Feel Better is great. All these things, we know these are really important things. And when you're going through a tough time, you really want to try to be feeling as best as you possibly can. So it's particularly if you don't feel in any way, if your oncologist is a man, they will not understand these things. Certainly all the men we work with are amazing, and they're absolutely happy to talk about these things. So don't be shy. That's what we're here for.
So Caroline, what would be, if you could give one piece of advice for anyone about to go on this journey, or anyone going on this journey, what would it be?
Well, wow, there's a lot of things I could say, but I think the one thing people dread the most is the word chemotherapy. And I think there's so many emotions associated with that. But what I would say is it should not be a nightmare. And I appreciate having breast cancer at all is a nightmare, but the chemotherapy itself, if you're really struggling, if it's awful, let your oncologist or your breast cancer team know, because we can make changes. There's lots of things we can change with the treatment plans and things we can do to help support some of the side effects. But if it's a nightmare, be honest. And if you're lying in bed thinking, I cannot go through this again, you need to tell us, because we can make things better.
Well, that's brilliant, Caroline. Thank you so much for sharing that. It definitely will help an awful lot of women who are about to embark on this journey. And, sometimes, you are afraid to ask the questions about, what am I to expect from each part of my plan. But I think what you have said is that everybody is treated individually. Everybody gets their own plan to suit whatever it is that they need. So yeah, that's brilliant. Thank you so much.
Thanks so much.
It's a pleasure. And say, I give all my patients an hour for their first appointment. So we're expecting you to be here. We're expecting you to ask for a lot of questions. That's probably not even enough. Sometimes we have to go over things again, but just do ask the questions and do use the support that's out there, because there is a lot.
Bring a friend or a partner or a husband or someone else to another pair of ears. Yeah. Okay. Amazing. All right. Well, thank you so much. And we will speak to you soon.
Yeah.
Okay.
Thank you, Caroline.
Bye.
Bye.